Just here.
Okay, I think
Okay.
we are recording. Great. Well, thank you everyone for coming to our January PCAG meeting at our new time. And thanks for everyone who filled out the survey. It was pretty overwhelming that folks wanted to keep Wednesday, so I didn't do too much tracking down of people who didn't fill out the survey since we really weren't changing things. But we did hear from a number of folks that starting at 5:30 would increase your ability to join. So we're going to try that out for a while or for the year, unless I overwhelmingly hear otherwise. So the plan is to have the PCAG meetings be from 5:30 to 7 on, what is it, the third Wednesday? Is that what? Yeah, the third Wednesday every other month. And we'll sort out the calendar reminders and all of that as well. Apologies for the confusion with the cancellation, but we wanted to make sure there was a phone line, so we had to resend it. Yeah, so our agenda for tonight, we are going to have a couple updates from Susan, and then we also welcome any PCAG members to give updates they may have. We'll spend about 15 minutes on all of that and just letting everyone have a chance to say hello. And then we have Pat Jones back with us to talk more about the AHEAD model and the primary care elements. And she has some slides she'll walk through, and then we'll have a discussion. I have marked at 6:45 to make sure we pause for public comment. If we have folks who aren't PCAG members on the line, but yeah, we will see if that comes up. I think PCAG members, Pat can give your preference, but I imagine we'll have more of a discussion like last time with the PCAG members. And then we will wrap up at 7. So I will hand it over to Susan.
Thank you, Julia. And I just want to say one thing. I only see PCAG members and like Pat and Jess and myself, and I'm hoping, I think it was listed publicly. I just didn't see any. Okay.
I joined from the agenda on the
Perfect.
website just to test it all out. So that's how I
Great.
got here, which means
Great.
hopefully any member of the public could
Great.
also get
And
here that way.
then wonderful. So welcome everyone, and thank you, Julia. I just have a couple of comments, and then I'll go through the attendance list. I'll call out the names so that Julia can mark who's here. But I did want to let everyone know that we released our annual report today. We'll make sure you get a link to it. We'll send an email to everyone. It's a really great report. I'm totally biased, but I'll just tell you, if you don't read it, if you don't want to read, I think it's like 47 pages. The executive summary really hits all the notes, and I'd really encourage you all to read the executive summary. So, and it's also located on our website. That's number one. Number two, the legislative session is in full swing, and we're very busy. This second year of this biennium seems to be the busiest I've ever seen. And Pat, you can probably confer, and you've been around for a while too. I've never seen it so busy. I think between the pandemic and the last time there, and then all the new members last year, that this year they hit the ground sprinting. So we've been very busy. Julia is actually testifying tomorrow on H766. I might get the number wrong. That's right. And I know there was a message that Michelle sent out to everyone, Michelle Wade, about that bill. And then there's some other bills that are making their way around the State House. I want to Julie, should I take attendance now, and then we'll open it up for any comments from the committee members or any updates?
We can, yeah. And I think I was doing a pretty good job marking names down as we were going.
Great.
So, and I heard Michelle say that Dr. Florence was with her. So 2 for 1 on that.
Great. If you have everyone, then that would give us a little time.
Yep.
We've a really good turnout tonight. It's great. So why don't we open it up for any updates here to start from the committee members. We'll also circle back at the end after I know Pat's here, so I want to get to her presentation, but just in light of legislative items and other things that might have come up since the last meeting, Julia and I wanted to make sure you had a chance to share any updates with us. And I just wanted to welcome Dr. Holmes, Board Member Holmes. I know she She doesn't love when I do the Dr. Holmes thing. Jessica Holmes, how's that? Okay. Lee, you had a thought.
Yeah, I just want to apologize for not being here for a couple of meetings because I was out trying to earn money to start my direct primary care practice, which I am going to do in about a month. So you will have a direct
Wow.
primary care person on this board.
Wow.
And so another perspective coming in.
Great. Congratulations. Wonderful. Thank you so much. Thanks for the update. Any others from the committee members? Faye.
I'm not sure if this seems like maybe the time to bring this up. It's something I don't not completely clear on, but I thought it would be worth talking about with the group when you mentioned the legislative stuff, Susan. I'm in an email group with some other folks who are interested in healthcare reform, and there's been a lot of discussion about this one S211, which appears, it's hard for us mortals to read legislative language, but it appears to take a lot of responsibility from Green Mountain Care Board and move it to the Director of Healthcare Reform in the Agency of Human Services, including stuff like some of the work that Green Mountain Care Board's done on, the prior authorizations and the quality measures and pilot studies and things that have felt like, to me, like some of the more important primary care oriented things that have happened in the last few years. So I just wondered, like, in looking it over and in hearing other people talking about it, I'm not sure what, it seems like there's has to be some master plan here or some reason for doing this. And what's that about? How does PCAG feel about it? How does Agency of Human, how does Pat Jones, how do you feel about it? Like, I'm just trying to understand it better. And I have some thoughts, but I'd love to hear what people who know more think about it.
Well, I'll just say and this might be the same for Pat. I think it is. There was a lot of stuff that we had no idea. Neither one of us had any idea was going to be in that bill. So that's a starting point. I don't think a great starting point that neither one of us was aware. I think it's good information to share. But I'll let the PCAG members talk, or Pat if she wants to.
Well, the only other thing I wanted to say is that I just have had a chance to start to look through it myself, but I hope, like, the prior auth stuff, because I got the sense that they were sort of striking that pilot section because we're kind of beyond that. That was from 2012, and we did a prior auth pilot. I don't know if Dr. Ramsey's on the call, but I know he helped lead that. And so I didn't take that as, taking the prior auth discussion away from Green Mountain Care Board and giving it to AHS. I looked at that more as it's no longer a pilot. That report was done, but I don't know. Susan, did you see it differently, or?
Again, we're still digesting it. We're all the board. Pat is going to testify on Friday as well, right, Pat? The Senate Health and Welfare Committee is taking Friday morning, starting at 9 a.m. testimony on S211. So I think we'll learn more about, where the language came from, what it means. The only thing I'll say about the pilot authority is, yes, you're right, Pat. We use some of it we actually use some of it for some of like the ACO stuff and the SIM work. And there was the work that Dr. Ramsey did. But, there'll be a broader discussion on Friday.
So among some of the other people that have been in this email group that I'm involved with, there's really a feeling, well, let me put it this way. In trying to understand it myself and talking to people about it, I have questions about whether it seems like an independent group is the most likely to be able to lead change in healthcare reform. I think when, people like Pat and Ina Backus previously are really incredibly knowledgeable and in deep in the weeds with all of these acronyms and how you negotiate a budget with the feds and all of that. But for real sort of vision on healthcare reform, like where do we want to take this state? How are we going to improve things? I'm not sure. That becomes then within the Agency of Human Services, sort of directed by the governor. And I don't know how much vision there is there, or at least that's been visible to me recently. So when I read this, I thought it felt like we might be taking some of the vision for healthcare reform away from Green Mountain Care Board and moving it to, and I thought that sounded like a shame, that keeping it in a place that was not at the direction of the governor or the administration, I should say. An independent board might be more likely to create change. I'd just be interested what other people thought.
I'll just say I would agree, Faye. I got the same impression reading over the bill as much as I could understand it. But I think a group that's somewhat more insulated from the whims of politics might be more effective, particularly in the long run. You need as you said, a long-term vision for healthcare reform. And, people making those decisions turn over every couple of years or 4 years or whatever. I think that would slow progress. So I'm not sure what the rationale. Maybe whoever introduced the bills will put forth some rationale for doing that. I don't see it right now.
Okay. Well, we'll make sure actually that we can actually send the recording from Friday. That might be something, or the link to it. All the legislative testimony now post-COVID, silver lining is they record everything, which is actually really transparent. So we can make sure you all get that recording so you can see what happened in committee. I think some of these questions might be answered by the folks who introduced the bill. Thanks, Faye, for bringing that up.
And I think they did a walkthrough of the bill too. I didn't get to listen to the whole thing. But it was, I'd say like last week. They probably did a walkthrough of the bill, and so that would be something that's recorded as well.
Good point, Pat. Thank you, Pat.
Is there any way that for those of us who might not have time to listen to the recordings, is there anyone within PCAG who could give us an update or a summary or an impression as this goes on? Is that a reasonable thing to ask?
Are you asking the Green Mountain Care Board folks, or is that one of your colleagues on the?
I was thinking, I said PCAG and I meant Green Mountain Care Board. Yes.
Okay.
Yeah. Sorry, I wasn't
You're
clear.
probably like, she's ignoring me.
No. I wondered if anyone from Green Mountain Care Board who's involved in those hearings could send out some sort of a little summary or update, just so, because it just seems sort of like there must be some reason, some grand plan, and I don't get what it is. And if anyone gets more of a vision of it, it would be great to share. Okay, that's all. Thank you.
Yeah, absolutely. Thanks, Faye. Anyone else? Any other updates? And then we'll turn over to Pat. actually turn it back to Julia, see if she has anything else before we turn it. You're all set? Okay.
I'm all set.
This is John King. Can you hear me?
Yes. Hey, John.
I just had a quick update. Some of you may be aware I'm involved with a planning grant from HRSA to develop a distributed family medicine residency among 6 of the Vermont FQHCs and their partner community hospitals. And I'm working with Melissa Volansky on this. The one thing that we noticed just on our first visit out to northern counties is that the hospitals are feeling very stressed by the budgets that they recently got from the Green Mountain Care Board, and that's reducing their appetite for engaging in a distributed residency program. So I just wanted to make people aware of that.
Thanks, John. And maybe we could talk off. I'm happy to talk to you offline, maybe reviewing. I won't get into it now, but the results of the budgets, just so you know, in the areas when you're traveling around, what happened. I think that would be really helpful for you, just so you have the kind of the lay of the land. If you have time for that, I'd love to do that with you.
Yes, thank you. Drop me an email and we can get together.
Awesome. And great update. Great work. Thank you. Anyone else? Any other updates? Okay. So we'll turn it over to Pat Jones now, Interim Director of Healthcare Reform at the Agency of Human Services. She's working with us today. We've been together since 1 p.m., right, Pat?
Pretty much, yeah. Yeah, and so
Good
if I
thing we like
lose,
each other.
yeah, and we do. And if I lose my voice, bear with me. I have been talking an awful lot today, and I would like to apologize in advance to anyone who was at the Green Mountain Care Board meeting this afternoon, because some of this, but not all of it, will seem a little redundant. But so what I wanted to do, I think the last time we spoke, I had shared what we knew, speaking about vision for healthcare reform. I had shared what we knew at the time about a new federal model that's being proposed. And we got more information since I last spoke with you. And so I wanted to just give you a progress report on that model, where we are and so forth. So Julia, you can go to the next slide. But I want to start, and I started this way this afternoon at the board too, because I realize sometimes we just sort of dive into, oh, what's this new model? But there's a lot of questions around why are we considering participating in a new federal model, and why now? So at its most fundamental level, healthcare reform is really striving to use public policy to address challenges in healthcare. And you all know better than I do, because you see it every day in your work, but what are the challenges that we're facing, and what are we trying to achieve? So here's a list of some of them. I'm sure that you could come up with others. And I'm just going to give you a warning. A few slides in, so kind of be thinking about this if you can. A few slides in, I'd like to open it up a little bit. We have a primary care work group that's meeting as part of the work on this model, and Dr. Florence has been part of that group, and I had mentioned it at our last meeting. But at our last meeting of that group, I asked them, what would great primary care look like for your patients? And I got a lot of, we got a lot of really good answers when we ask that question to that group. So I'm just giving you a heads up that a few slides in, I'm going to ask for some dialogue on what great primary care would look like in your view. But anyway, the challenges and goals, we're trying to ensure affordability. We're trying to improve access to care and also access to insurance coverage. We want to optimize the quality of care and the experience of care for the people that seek care. We want to improve the health of the entire population. We also want to improve equity and reduce disparities in health and healthcare and health outcomes. We strive to identify and address social determinants of health. As you all know, workforce is a huge challenge. So we're trying to ensure that there's adequate workforce, not just in hospitals, not just in primary care, not just in specialty care, but really across the entire care continuum. We talk about trying to reduce complexity as well. And we had what I would say was a very complex presentation this afternoon at the board about the mechanics of hospital global budgets. But, we really want to try and reduce the complexity of what things look like out in the communities, out in the field. And from, I think, your perspective, because I've heard you all be very eloquent on this, that includes where there is misalignment across payers, different formularies, different prior auth requirements, different quality measures. So, that introduces complexity into the system as well. And then we want to create a sustainable healthcare system. I think there's a lot more we could, and I'd love to hear your thoughts on that when we open things up too. But, this is a list that, we hear a lot from folks. And, people really focus on payment reform and, it's critical. It gets a lot of attention, but we think of it as really a component of healthcare reform. It's not the goal. It's really a means to an end. And the goal is that the payment changes that we make would support and encourage transformation in care. And then the end result would really be better health outcomes and better population health. So, sorry to spend time. I hope I didn't spend too much time on that. It may seem sort of rudimentary, but, I realize that when we just dive into these models, we sometimes kind of forget the why of what we're doing. So the next slide talks a little bit about why now. So I think you all know we have a current all-payer model agreement with CMS, the Centers for Medicare and Medicaid Services. It's between the state and the federal government, the governor, the AHS secretary, and the Green Mountain Care Board chair all signed that agreement back in 2016, late 2016. What that model does is it really allows Medicare to pay for health care differently in Vermont. And that's the authority with which they can do so. And it also creates that alignment between Medicaid and the commercial insurers that participate in the model. All of these federal models, and you'll see it in the material I present tonight on the AHEAD model, but all of the, CMS always establishes state level accountability in these models, and it's generally around cost, population health, and quality. This new model also has a really strong focus on equity. So, what we were able to do was change from paying for each and every service through a fee-for-service model to more prospective, predictable payments. Those payments are linked to quality, so they're value-based payments. And the triple aim is really what we've been after here with healthcare reform. I mean, if we have a North Star, it's that triple aim of reducing growth and healthcare costs, maintaining or improving quality, and improving the health of Vermonters. And that came from the Institute for Healthcare Improvement back in, I don't know, it was the early 2000s. And I noticed that just lately that, there's been a lot of talk about the fourth aim, which is improving practice for providers. And they're now, there's an IHI is actually, they were kind of sticking to their three aims, but they're starting to really say, yeah, there's a fourth and even a fifth aim. And the fifth aim is advancing health equity. So you're starting to see people talk in terms of a quintuple aim. So as you know, the model we have now relies on, and I see Dr. Wolfman here, the model relies on an accountable care organization. In the case of this model, it's One Care Vermont. It's a voluntary network of providers that agree to be accountable for care, cost, and quality. So originally the model was set up for 5 years. 2018 was the first performance year, and it was supposed to go through 2022. Because of the pandemic and some, CMS really wanting to stand up a new model, we're in a 2-year extension period with that model. So it's currently set to end at the end of this year. We are in discussions with CMS about extending for another year through 2025, because as you'll see, they won't have a new model ready for 2025. So next slide. Why do we care about continuing to include Medicare in Vermont's healthcare reform efforts? There's a number of reasons that we've listed here. One is that Vermont is a quite low cost state for Medicare, and so by continuing to be part of these reforms, Medicare recognizes that. They do evaluations that show that the models we have saved Medicare dollars. And, there's sort of that top three boxes all hang together because, it allows us to influence Medicare reimbursement for Vermont providers. So it's not just, fee for service, but there's some more creative payment models there. And they also will recognize when they do their baseline financial calculations for these new models, they'll recognize that, yeah, Vermont's past reforms have saved money for Medicare, and that, changes how they set financial targets for us and so forth. There, on that bottom row, we get between $9 and $10 million every year. Well, this year it's close to $10 million that covers Medicare's portion of the Blueprint for Health payments in Vermont. No, we were part of a demonstration project with the Blueprint that several states, I think it was 7 or 8 states were in. And Vermont was one of the only states that showed savings from that advanced primary care model. And plus we had the support and services at home program as well that serves Medicare members through, housing organizations with wellness, nursing, and care coordination. And that nobody else that I'm aware of has that program, at least not statewide. And both of those programs showed big savings for Medicare, and so they liked it enough to keep the payments going. The only way they're keeping them going is through the ACO. but they've indicated that they're interested in continuing them in a future model if we end up participating. So that's been good. And then, part of Medicare being involved is that they can sometimes waive Medicare regulations that don't allow for payment for some services. And a clear example is there's a requirement that Medicare members have a 3-day stay in the hospital before they can be admitted to a skilled nursing facility. And we have a waiver that allows direct admission to a skilled nursing facility. And we have the ability to propose new waivers as well. And the ACO has been very helpful in implementing those waivers. And then finally, back to that alignment principle, but, having Medicare and Medicaid and, any commercial involvement that we can get, it helps us align these priorities, payment models, quality measures, reporting, and so forth, which reduces administrative burden and sends signals about what's important. So lots of reasons to want to keep Medicare in our healthcare reform efforts, not to mention that they're a significant payer. Next slide. So what's this AHEAD model? And we've talked about this a bit before, but it stands for States Advancing All-Payer Health Equity Approaches and Development. And so on September 5th, actually right before the Innovation Center leadership came to Vermont for a site visit, they announced that this model was going to be released soon. And on November 16th, they actually released the Notice of Funding Opportunity. We call it NOFO for short. And it's really an invitation for states or sub-state regions. So the state has to be the applicant, but it can be for the entire state or it can be for a region of the state. So it invited states to apply for the model. The focus of this funding opportunity is really, first of all, there has to be an application, and the focus is on, does the state have capacity to implement this model? And then they're also offering up to $12 million total over about a 6-year period. So, think roughly $2 million a year in what they call cooperative agreement funding. So that's actually money that the federal government grants to the states that they select for this model to support implementation and the transformation that would be required. There's only going to be 8 states or sub-state regions selected for this model, so it is a competitive application process. I put a link to the website there. The applications for the earlier states, there's 3 cohorts. The first 2 have to apply by March 18th of 2024. And Vermont's intent is to apply in that first cohort. But I want to note, because this is really important, that, submitting an application, number one, doesn't commit us to jumping into the model, because there's still a lot of details that have to be negotiated and worked out. Number two, it doesn't mean that we're going to get picked. So again, it's a competitive process. So the application should really be thought of as the first step, really the start of a more formal discussion process with CMS, not an end point. Next slide. So this shows the timeline, and sort of the first thing I want to point out, because it's pretty evident from this graphic that CMS provided, this is a longer term model than what we've seen in the past. The current model, as I said, was initially 5 years. I think, between the pandemic and just how long it can take to stand these things up, we realized that we could use a bit more time. But this one goes through 2034. So depending so the cohort 1 states have to, and cohort 2 states have to apply by March. the difference is that for cohort 1, there's an 18-month, what they call a pre-implementation period, where details get sorted out, payment systems get changed and so forth. And so the start date would be January of 2026. So there are 9 performance years for the cohort 1 states. Cohort 2 gets a longer implementation period, and so they have 8 performance years. And then states that want to try but aren't ready to apply in March, they would have till August to apply, so not that much longer. And then they'd have sort of a middle of the road pre-implementation period and would again start in 2027. So those states, cohorts 2 and 3, get 8 performance years. Cohort 1 gets 9. Next slide. So here's some key dates for cohort 1 states. And again, that's what we're thinking of applying for. So in big red, March 18th, about 8 weeks from now, applications are due to the federal government. And it's a very intensive application, as you can imagine. CMS is saying that in May, probably late May, they anticipate notifying states that have been selected. And they've said that for cohort 1 and 2, the ones that apply in March, they're going to award no more than 5 states because they want to keep out at least 3 slots for the cohort 3 states. And then that pre-implementation period, if you're selected, then there's, discussion and sort of an agreement to accept the funding. It's not the final state agreement, but, agreement to accept that $12 million in funding. And so the pre-implementation period would start in July and carry through July of this year and carry through December of 2025 with that start date of January 1 of 26. Next slide. So here we go. Before I get into the details of what CMS is proposing for primary care, and it's pretty interesting what they're talking about, I just wanted to take a minute. We were talking about vision, and it's really helpful for us to hear from you. Given your work now, what would great primary care look like for the people that you work with in your practices, your patients? So anyone just jump in if you have thoughts on that. Go ahead, Dr. Lepresti.
Well, long time ago, I read that the currency of primary care is time. And we need the time to do what we need to do. There's been studies of electronic health records that show that it takes a primary care physician 15.8 minutes on the average on Cerner to document a note. We get 15-minute office visits. How does that happen? It doesn't, is the answer. So somebody needs to make a decision that they're going to give us the time to do our jobs. And if we can't listen to the patients, if we can't talk about options with the patients, if we can't do that stuff, you're not going to get great primary care no matter how you design the payment system or anything like that. I mean, we have to figure out how to give people more time with their doctor for the appointment, not for the documentation.
Thank you. It's very helpful. Dr. Homan.
I mean, there's, I think, availability, being able to see your provider when you want to, not having to keep for the providers, not having to keep your schedule packed so full in order to meet meet expenses for your practice, really being available having primary care close to home. People don't have to travel. How about everyone in the state has a primary care provider? That would be, I mean, this is something I've said other times. That's really the only quality measure we need in this state. Everyone has a primary care provider and has seen them in the last year. All the other quality measures could go out the window if everyone had a primary care provider and had seen them in the last year. So availability, affordability, and a truly primary care based system. You know, I could go on and on about this, but we all need and value our specialists. Many of them are not able to be available to us because they're doing primary care in their specialty practices. If we moved primary care out of specialty practices and into primary care, and there were enough of us to actually do it, then we could use specialists the way at the value for which they really present to the patients. Those are some thoughts. I could go on and on.
Great, thank you. And it looks like Katie Marvin.
Hi.
Hi.
Thanks for having this. I mean, to me, it comes down to just math. So when I think about my patient panel, you know, I have a panel of about 1,500 patients, and I see patients for 24 hours a week, and then have about 10 hours of additional time. I'm part-time, so you can prorate that one direction or the other. I think that panel size for one primary care provider, given the complexity of medicine, the aging population, is actually a little too high. It probably should be more like 1,200. So if you want to just do the math, you can figure out how many primary care providers we're lacking. The second part that's really important that I think we need to work harder on, and I've been really working on just at like individual levels, is talking with our specialty peers and really, I call their cell phones now and say, okay, you've been seeing John Doe here for really pretty well controlled hypertension for 6 years after he had a, bypass surgery or something. Why do you need to keep seeing him? And a lot of times the answer is, well, I really don't. Like, I actually had this conversation with Adam Kuhn like 2 days ago. He's like, I don't really, he's fine, but I just really like him, and he's nice, and he wants to see me. And those reasons for patients to actually determine their level of care and require or request and have it granted to them to have an appointment for the same exact issue that's 4 times as expensive. It's amazing to me that the insurance companies are paying for it, because it's really out of patient request in many cases. So I've been like, even just this week, I talked with an allergist at Timberlane about this exact same thing. I talked with a rheumatologist recently about it. This patient sort of self-directed care that in many cases is granted is costing us a ton. But it is a chicken and egg situation. While we probably in primary care could absorb and are competent to manage 50% of what goes to a specialist, I think we're beyond the point where we could actually accept it back. Because of the numbers that we mentioned earlier, the panel size issue. And as we were talking about earlier, just those hours, you can't see patients for 40 hours a week because of the amount of paperwork that's required. So anything we can do to diminish that's important. So you have to think of a full-time provider at about 30 hours to make up for that extra time. And with the current workforce, which is probably 60% female, it's hard to work at that 1.0 FTE. And so anyway, it's not that hard to actually do the math and figure out how many FTEs we're short, how many providers we need, and then what the cost difference would be if all of those unnecessary specialty visits were redirected to primary care. I think you could really boil it down to numbers and just say, like, this, we would save tons, millions and millions of dollars.
Thank you. That's a really good sort of systemic view too, as well as an individual patient view. So thank you. Dr. Tanner.
Yeah, I'm going to take a little different spin on it. I think of primary care as, I sort of break it into a couple different buckets. one being preventive and one being sickness. And I've always counseled our staff that there's just too much to think about for one person to manage all that. So I think primary care has got to be team-based. I try to promote that, the clinicians are going to be the ones dealing with the sickness and put on the nursing staff to be sure they take ownership of the preventative services, to break it down that way. There's also buckets of acute versus chronic care. In chronic care, I think it can be further divided into, can we prevent certain chronic conditions, or what's the optimum way to manage them? And that then often involves other team members to help with housing, with food, with transportation. So there's got to be a team approach to good primary care.
Thank you. And looks like Dr. Wade.
Hi, thanks. I want to kind of piggyback a little bit on what was just said. I think that we're losing a whole lot of workforce by not allowing and having registered nurses and licensed practical nurses work to their fullest scope, which can support the providers in 100 different ways. And there are some really outdated and stupid rules out there. One of the more recent issues is that right now, for providers to get medications refilled, the nurses can't queue them up and send them electronically anymore because there's a pharmacy rule that says that that's nurse prescribing. And these are the things that take an inordinate amount of time for providers to go through that they shouldn't be spending time doing. They need to be spending time making the right medical decisions and clinical decisions and allowing the nurses to do the preventative and primary care things that are within their scope. And we need to look at making sure they're working to the fullest.
Thank you. And Dr. Wolfman.
Hi, Pat. I agree with everything the others have said. I'm a big fan of team-based care. And so the point I want to make is that primary care needs more money. It needs enough money to run the business. I'm also a big fan of, you can call it capitated payments or lump sum payments, but enough money based on the patients who go to a clinic and sort of how sick they are. How much money does it take to take good care of them using team-based care? And then also allowing the providers to do the right thing for the patient. So maybe that's a home visit, maybe it's telehealth, but when there's enough money, it allows for more creativity, flexibility, and sort of meeting a patient where they need to be met, instead of just, like most of us, waiting for a list of sick people to come in so that we can bill enough to keep the doors open. So I'm a big fan of the CPR program that OneCare has created, or something similar to that to support primary care so that we can actually run the business and do it the right way.
Thank you. It looks like Elliot. Can't see your last name.
So I think, primary care has to be sustainable. And I think for that to happen, there has to be a priority in the training back in medical school and even beforehand, that people want to go into primary care. And that probably has to do with, obviously, the money that's going to be paid for it. But my experience, people are coming out of training and they're deciding early on that they're not going into primary care. They're going into some subspecialty. And so there's got to be an emphasis on there. And from what I can tell, it doesn't seem to be their priority.
Thank you. And Dr. Lopresti again.
Just wanted to fully agree with Michelle, but with a twist. She was talking about getting the LPNs and the RNs to work at the top of their licenses. I would dearly love to work at the top of my license, but I spend a whole lot of time doing stuff that's way below the top of my license, and that is just not productive. To some of the people who have mentioned money, I don't know the answer to this. I don't know how much Medicare pays for healthcare in this state, but I did a little bit of math based on what you've said so far, and you're talking about 8 performance years with $12 million available. That's $1.5 million per Vermonter per year, and that is $250 per Vermonter, $2.50. That's not going to change anything, folks.
I'll share a bit more later about what the model is for primary care. That $12 million is, to stand up the model, but there is some funding in the model for primary care. And then it looks like Dr. Penny, and then I don't want to shut things down, so I want to I want to keep this dialogue going either at this meeting or the next one. But let's hear from Dr. Penny, and then we'll move on.
Okay, well, this has been touched on, but I think great primary care would be involve having the resources outside of the office that our patients need, mental health being obviously one of the biggies, but adequate home care, adequate rehabilitation for the people that need that, and as our population ages, more people need that. So, I mean, any number of things, but our job in the office would be easier if we had confidence that, that when the patients leave, they can get the additional supports that they need.
Yeah, we hear that
and
from the hospitals as well.
Yeah. And just one thing I'd like to, on one of your earlier slides, I'd like to commend you for including the concept that payment reform is not in and of itself healthcare reform. I've never seen that stated before, even though I've always thought it was obvious. So thanks very much.
Thank you. Okay, this was great. I hope you don't mind, but I'm going to take these comments and meld them with what we heard from the primary care work group. And I think this is going to be a really rich, we talked about vision earlier, and I think you and your colleagues have really laid out some great vision here. So thank you. I really appreciate you taking the time for that. Okay, let's dive into the AHEAD model. So this is a very busy slide that CMS put together, but I actually think it does a pretty good job of showing the components of the model. So I had mentioned earlier that in all of their models, CMS really has state level accountability. They tend to sign these agreements with states, and they want the states to be accountable for various targets. And in this particular model, there's 3 categories of state accountability targets. The first is, as expected, total cost of care growth. And they're talking about your Medicare Part A and Part B type services, so your hospital and professional services. And they'll be looking at 2 measures for that. One will be for the traditional Medicare fee-for-service population in Vermont, and the other, or any state that gets selected. And the other would be on an all-payer basis. How are we doing on total cost of care? We have something like that in our current model, so it's not unknown to us. The second area is novel. They would like to see increases in primary care investment. So again, on the Medicare fee-for-service level and also on the all-payer level. And so they'll literally be, providing a metric that looks at what are total healthcare expenditures and what percentage of that is devoted to primary care. And the Green Mountain Care Board and the New England states in general have sort of been leaders in this area, but the Green Mountain Care Board a couple years ago put out a report that shared the level of investment in primary care in our state. And so we have some capacity to collect that measure. But to me, it was really heartening to see that one of their goals in this model is to see increased investment in primary care. And then they also want at the state level there to be, quality, population health outcomes, and equity measures that the state is responsible for meeting. So that will be in the model as well. They identify three components for the model. We already talked about that cooperative agreement funding the $12 million. And, they have certain ideas on how states should think about using that funding. A second component, and I think you've probably heard about this, is that they're looking to do hospital global budgets. So instead of paying for individual services or even the model we have now, where there is a prospective payment that comes in from Medicare on a per person type basis, they're looking for hospital global budgets that are based on prior revenues. And so the hospital, it would be not reconciled to fee for service. It would be flexible. It would be predictable. It's complicated, as we heard this afternoon, but it's a pretty different way of paying for services that hopefully would lead to care transformation. And then the third is primary care ahead, and I'm going to do a deeper dive on that this evening. They talk about several strategies to meet the goals of the model. Well, equity is central to this model, so they want to see equity integrated across the model. For example, hospital global budget payments would be adjusted for social and medical risk. And so, a hospital serving more vulnerable people would get higher payments, and same with primary care. So, but there are many other places where they infuse equity into this model. Mental health and substance use disorder treatment integration is another strategy. And we've done some work in that in Vermont that tends to put us in a pretty good place there, but there's a lot of work to do, as Dr. Penny noted. An all-payer approach, and by that they really mean multi-payer, so Medicaid and Medicare for sure to start, and then commercial coming in by year 2 of the model. They want to see alignment with Medicaid, so they want to see Medicare, Medicaid, and ultimately commercial insurers have a lot of alignment. And then they want to try to accelerate existing innovations in states. I'll give them like a B or C on that in this model. A state like Vermont, where we've done an awful lot, they listen to us on a lot of things, particularly around what they would expect from primary care. But there's some areas where it's a bit of a step backwards. So next slide. So here are the goals. These are, the next few slides are actually theirs. They seemed good enough to me. They're pretty solid slides, so I'm just using them. But these are the goals that they outline for primary care ahead. The first is, again, that increased investment in primary care. The second is that they want to see that payer alignment. And the way that translates in primary care ahead is that they're really, unlike with the hospital global budgets where Medicare is saying, here's kind of how we want to do it. We might give you some flexibility, but we're going to call a lot of the shots on hospital global budgets. They're really looking to Medicaid to say, what are you doing in primary care? And particularly, do you have like advanced primary care models? And if so, Medicare, we're going to come to the table. We're actually going to come to the table with some funding, but we're going to let Medicaid take the lead on that. And so as part of that, they really are trying to support advanced primary care. And by that, they mean mental health and substance use disorder integration, where possible, into primary care coordination. Again, Dr. Penny had talked about some of those services outside of the practice, and they really want to see screening for health-related social needs, and they want to see addressing of those needs. Really supporting that advanced primary care. And then they're very focused on trying to get all types of practices in this model. So small, large, we don't really have that many large practices here, but independent, definitely federally qualified health centers, rural health clinics, hospital employed practices. So they want to see a wide range of practices. And then to Dr. Wolfman's point, this model doesn't start with a capitated payment, but they are, and that is a bit, in some ways the primary care work resonates because it looks similar to what we're doing in Vermont. But in one area, and that's that capitated payment area, that certainly the independent practices have taken advantage of with OneCare, and hospital employed practices have been getting prospective payments too. They couldn't stand it up for 2026, but they're talking about really trying to have a capitated track for 2027. And if we end up being selected for the model, we might actually have an opportunity to share. They know, trust me, the people at CMMI, they know what CPR is. If we say CPR to them, they know exactly what we're talking about, because we share and advocate and so forth, and they know that it has made a difference for independent practices here. So those are their goals. Next slide. How am I doing on time? This goes till 7, is that right? Okay. And do I get the whole time?
Yeah, we would usually take a second for public comment, but I haven't seen anyone who's not a PCAG
Okay.
member. So yes.
Okay, I'll try not to take the whole time, but I just
Okay,
wanted to
maybe,
get us
well, if there are any other updates from the PCAG members, but yeah.
Okay, I'll try and stop early. I forget how many more slides I have, but hopefully not too many. So a big component of primary care ahead is that, in addition to that statewide goal of increasing investment in primary care, Medicare is prepared to provide an enhanced primary care payment. We will now refer to it as EPCP, to support primary care. And that would be, again, for Medicare fee-for-service members. It's not for Medicare Advantage members, but still, it's it's a fairly significant investment compared to what we usually see. So they're saying that that participating practices would get an average of $17 per beneficiary per month for those folks who are attributed to the practice. It would be paid quarterly. That's an average. So I said there were adjustments for social and health risk. There might be some other adjustments related to quality. You can see that a small portion of that $17 would be, at risk for quality performance. But it would not go below $15 per beneficiary per month. It could go up to $21. So that's the range that they're talking about paying. What are the requirements? The practices, in order to participate in primary care ahead, they have to be part of the state's Medicaid Advanced Primary Care Program or Patient-Centered Medical Home Program. In our case, that would be the blueprint, and virtually every primary care practice in the state participates in the blueprint. So yeah, again, I think we're in good shape on that for practices that might want to participate if we end up going forward with this model. They also have to meet some care transformation requirements, and they want, Medicaid, again, to sort of take the lead on what those are, and I'll dig in a moment on those, but you're going to see that they look a lot like things that you're already doing. And then potential uses for the additional dollars. They talk about things like investing in infrastructure, staffing to help with advanced primary care. So it could be care coordinators, mental health, substance use disorder staff, community health workers. So, it's pretty open-ended, but that's what they identify as examples of potential uses. So it looks like Dr. Tanner has a question.
Yeah, thanks, Pat. Does the average $17 per beneficiary per month, is that in addition to Blueprint money, or does that replace Blueprint money?
So that's a great question. And what they have indicated to us is that right now, the Medicare portion of the Blueprint payments is for the practices. So you probably know that the Blueprint payments, there's what the practice gets, there's what the community health team gets, there's what SASH gets. That's how Medicare finances their share of our program. What they've suggested is, and I have a graph at the end that's going to kind of highlight this for you.
Yeah, Pat, I was going to ask, do you want me to just hop ahead?
Yeah,
Is it
why
this
don't you
one? I think
top
we're really close
that's
to
the
it.
one. Yeah. Now
Okay.
this is another sort of busy, ugly slide that we put together, but yeah, that's a great move. Thank you, Julia. So Medicare on the far left, that's what Blueprint practices currently get from Medicare, is that $2.15 per member per month. So CMS is implying that, that they're not going to pay that again. So the $17 would include that. But we're trying to show, what does this look like for the different practices that get support from, programs either from Medicare, or quite frankly, it's on behalf of Medicare, because a lot of these payments that you see here, Medicare isn't really kicking in right now. It's often the hospitals through the ACO. So I just want to be clear about that. The $2.15 they are kicking in, that's about it from Medicare. So if a practice participates only in the Blueprint and they're getting the $2.15, obviously the $17 average is quite a bit more than that. The second column there is if they're participating in the Blueprint and the ACO, but not the CPR program for independent practices. So those practices currently get $2.15 from the Medicare share. They get another $4.75 in a population health payment from OneCare. For their Medicare fee-for-service members. They have the opportunity to earn up to, it was $1. I heard recently that that's gone up to like $2.50, but there's also some of that's at risk. I think could be shared savings or losses, but it's somewhere in that neighborhood. If they're in the Blueprint and the ACO, but not CPR, it's still quite a bit less than that $17 average. And then for practices that are in CPR, they get all the other things, the $2.15, the $4.75, they have the chance to earn up to the dollar. Then they get a $5 per member per month payment to support participation in the CPR program. And then I couldn't go any further than that on this, because there's some, they get a prospective payment, so that might be more than what they would get fee for service, and that's for like your core E&M codes. They get 105% of the fee for service payment for services like labs or whatever that not all practices offer. So it's a little hard to tell, for the CPR practices, what happens there. There's a mental health component that they can earn. So, but that's getting closer to the $17, but it's still less than that. So it depends where the practice falls. as to, how much it means, but it definitely looks like it means, it's more, it's certainly more than what Medicare's paying now. Medicare's paying the $2.15. That's my understanding. They don't contribute to the population health payment. They don't contribute to CPR. But even for those practices who are getting all of the above, they still, it looks like, would get a bit more from this Medicare payment. And certainly the state would be getting more from Medicare to support primary care. So sorry to throw this denseness to you at 6:40 p.m., but that's that's how we've tried to look at this. It's a little hard to get it exact, but it gives you a feel for it. So thank you, Dr. Tanner, for taking us down a rabbit hole that we were going to go down anyway. So okay, let's go back to where we were. Did I? Yeah. So I got through that slide. Yeah. So let's go this next one. This is, these are, you should think of these as examples that CMS has provided about what they want to see in terms of care transformation for practices that participate in primary care. But I just want to say this is going to look a lot like some of the work that you're already doing, particularly under, for those practices that are blueprint practices. A lot of this stuff is happening. So let's start with health-related social needs. Examples they give are, screening for health-related social needs, having good relationships with your community resources and organizations. And frankly, every area has a community health team that actually does that. And that's supported by multiple payers through the blueprint. And then they talk about incorporating or embedding, social workers, community health workers, or other folks who would help with that resource coordination. My sense is that most practices in Vermont either have access to this type of resource or are already doing it themselves. So it's that team-based care that was referenced earlier. And then mental health and substance use integration. We try to stay away from that term, behavioral health. It can be confusing. So we use mental health and substance use disorder, but there it's, reporting on some quality measures. I know that, there's some focus on follow-up care and other types of mental health and SUD measures. Warm handoffs to mental health providers. That could be at your community mental health center or in the private sector, or it could be, embedded folks. And then medication management for people with complex conditions. And then care coordination. Again, these are examples, but they talk about those relationships with specialty care providers and referrals and, making sure that Medicare and Medicaid referral systems are aligned. But I think we feel like, given all the work that's been done in Vermont over the last 10 to 15 years, that there's, in a way, they really talk to us about what we're doing. And in a way, we sort of feel like this was patterned on what's happening in Vermont. Not that it's all perfect, but we've got the infrastructure, we've got the participation, we've got the relationship. So. Okay, so the next slide we'll skip because I already talked about that. I'm not going to go deep on this, but I did put it in here because I wanted you to see, like, that March 18th application that's looming over us. These are the kinds of things they're looking for. So for statewide accountability, you'll see a big focus on, can you measure primary care investment? How are you going to set targets for primary care investment as well as total cost of care? Can you get information from commercial payers and from Medicaid? Yep, we can. We have an all-payer claims database that's a big help. And, we've done this before, the Green Mountain Care Board has. How are you what policies are you going to use to, support increases in primary care spending? And are there gaps in the reporting? So it's really looking at, what are you doing now in this area and what are you planning to do in the future? So next slide. And then similarly, for primary care, they want to see, again, what's Medicaid doing in primary care? Well, we can answer that. How will Medicaid increase investment in primary care? What are the tools that can be used for that? What about access to primary care? Do you have a model, a primary care model? Yep, we do. So, and how are you going to recruit practices to participate in the AHEAD model? So, again, they're looking at what's your current state and what are you going to do to help move this model along if you end up participating. So next slide. I think I only have a couple left, but I did want to mention the quality strategy. So when they talk about quality in from this NOFO, they say there's 3 sets of quality measures: the statewide measures, and they give some examples of what they want to see. There's primary care, and there's hospital quality programs as well. And they really focus in on 4 domains: prevention and wellness, population health, and that's really focusing on your chronic conditions and whole person care, mental health and substance use disorder treatment, and then healthcare quality and utilization, which is more around experience of care and avoidable care. So next slide. So when we think about, yes, we look at those 3 domains. We also, or 3 areas of measurement, we also have added a 4th, which is that we really think that there needs, if we were to move ahead with AHEAD, we think that, you'd want to do some broader monitoring and evaluation, a lot using claims and other measures, not adding burden, but how do you look at, is what's happening with utilization? You want to make sure that people are getting the care they need, as well as making sure that they're not getting care that they don't need. But you definitely want to keep an eye on some key things like access and utilization. So we think there's sort of a 4th area. And align, try to align across these areas so that there's not, proliferation of measures and measure confusion. And I think I might just have 1 or 2 more slides. Yeah, this is so this is what they're saying for AHEAD primary care. They're saying that they will require 5 measures for practices that participate in the model. They also, they list them. They list some of the, some of them you get to pick from, but, some of them are required. But they also say that there might be some flexibility to propose alternative measures, that align with things that are already happening in the state. As long as those measures align to one of those 4 domains that we talked about, or to the goals of the model in a broader sense. So you can see what the measures are. For prevention and wellness, they're saying, select one of these if you go with their measure set. So colorectal cancer screening and breast cancer screening. These are measures that are by and large familiar to us. Chronic conditions, controlling high blood pressure and hemoglobin A1C poor control for people with diabetes. These are measures that are in multiple sets of measures in the state, and in fact, areas that we've worked on from an improvement point of view. For mental health, and so choose one of those. So choose one prevention and wellness, choose one chronic condition measure. And then for mental health and substance use disorder, the measure they've identified is again one that's quite familiar to us, screening for depression with a follow-up plan. And that one would be required. And then they're saying that for healthcare utilization, both of these measures would be required. So here they're after avoidable care. I'm going to put air quotes around avoidable because we know all kinds of reasons why people land in the ED or inpatient. But so they, are focusing on emergency department utilization and acute hospital utilization. So that is I don't want to call it a whirlwind tour because I feel like I talked your ears off, but it is a tour of what the AHEAD model looks like with a focus on primary care. So thank you for your attention and patience. I'm happy to answer questions either now or, after the fact, and would love to hear your thoughts and feedback. So it looks like Dr. Penny first, then Dr. Homan, and then Dr. Wolfman.
Just a couple of thoughts specifically regarding Medicare. Value-based payment instead of fee-for-service certainly is the way to go. It looks like capitation seems to be the method. That could work well when things are stable. I'm wondering what happens when there are major adverse events like pandemics, climate-related events like floods, mudslides, forest fires. It's going to have a big impact on the community's health, and very likely make it more difficult for practices to cope with that. So what happens to the payment scheme to keep the system running in those circumstances where a lot more resources are going to be required? And then there's Medicare itself. Trust fund for Medicare is being depleted fairly rapidly. I forget what the target date is, but I think somewhere in the 2030s, runs out of money or runs low on it. Obviously, that's up to Congress to fix, which doesn't make me feel real good about the outcome. So anyhow, I hope somebody somewhere up there in the hierarchies of planning this, somebody's thinking about those things.
Yeah, a couple comments. If past experience is anything to go on, and I don't know that it will be here, but what we've seen in other models is that they'll offer a capitation track, but practices don't have to take it. They'll offer options. So that may or may not be the case in this model, but we haven't gotten a sense that they're going to say you have to do capitation. I guess the other thing I'll say is that the catastrophic event that we've lived through is the pandemic. And what we saw then, because what was happening then was people weren't getting care. And so they were staying home. And so these prospective payments for those practices and organizations that had prospective payments in place, they were a lifesaver. Because revenues otherwise would have plummeted, but they just kept getting their prospective payments. Now, in the case of something like other examples that you gave that would increase utilization and, that would really have health impacts, and, there tend to be, what they call exogenous factors, clauses in these agreements so that if something catastrophic happens, that there's a way to deal with that. That does not address the concerns that you posed about the solvency of the Medicare Trust Fund, however. But they do tend to have something usually that says if some kind of catastrophic event comes into play, we'll mitigate for that. So we would probably want to do that. So, Dr. Homan.
I understood from one of the other times we talked about this that current the current system is sort of sunsetting as to how this money flows into the state, and so that it was necessary that something changed. And now you're saying this is competitive and we might not get it. And so my question is, what if we don't? What system were we working under then?
Yeah, if we don't, if we don't get, say we don't get the model, we would probably be looking at going to fee for service. Now, some of you already get fee for service through Medicare, but there's been some gains in Vermont in terms of different ways of Medicare paying for services, and the sense is that we would revert back to fee for service. There might be an opportunity to participate in a Medicare shared savings program because they're available, but that would likely fragment what's happening in Medicare with other payers. So it's definitely something we think about and have concerns about, but we do intend to apply. I think the question after that is, do we get selected? They've shown quite a bit of interest in Vermont. When they announced the model, they highlighted 3 states that they really were looking to build on, and it was Vermont, Maryland, and Pennsylvania. So, they definitely know who we are and what we're trying to do here, but it's not a done deal that we get selected. And then if we get selected, then we have to have an agreement that actually makes sense for our state. So. Thank you. Dr. Wolfman?
So I think it's really important that practices understand whether or not they will be responsible for the electronic reporting of their quality metrics in this program, or if that will be state assisted in some way. I know working at OneCare, we still have members in the state that don't have certified electronic health records. So how will that work in this model?
Yeah, I think that's TBD, Dr. Wolfman, but it's definitely an important component. Some of those measures that I outlined of the 5 measures rely on clinical data rather than claims data. And so in that case, CMS is indicating that they would want data to be reported through their electronic clinical quality measure system. And it would be helpful for us to know what the capacity is out there for practices to do that at this juncture. And then how, they've talked about technical assistance and, whether there's resources that we could bring to bear to help make that happen, or whether there's a, centralized organization, a management services type organization, doing some of what I think the ACO is doing. So, I think we have to sort that out, and fairly quickly. I did want to mention on the quality measures, they they are putting a little bit of that payment at risk. They're talking about 5% to start of that average $17, and then maybe moving up to 10% by, say, performance year 8. So I did want to note that but there's also the ability to earn extra if health disparities are reduced. So there's some upside stuff and a little bit of potential downside, but again, that floor of $15 for the payment is what they've put out there. Dr. Lopresti.
And if I can just jump in for 1 second, I want to acknowledge it's about to be 7 o'clock. Would love to leave the last word, and then Pat, any last word that you have. And then I just want to make sure it's everyone I know has had a long day, so I like to honor our end time. But maybe I'm saying I'm cutting off hand raising, but if there's more discussion, we can facilitate that offline. But go ahead, Lee.
I will make it as quick as I can. One of the things you've heard from us in the discussion was all of the stuff that drops down to primary care and all of the paperwork and the other stuff that we have to do. What I'm hearing from this plan is more paperwork, more people to supervise, more people to contact, more money going out to, mental health and substance use people. None of this looks like it's going to the primary care people. I don't know how you decide what primary care spend is, but if the primary care spend goes to the practices and it doesn't go to the clinicians, you're not going to get more primary care clinicians to do this work. It has to go to the clinicians. We are underpaid and overworked. And
So go to salaries as opposed to practices.
correct.
Okay, thank you.
Well, that was efficient. Thank you. I was like waiting in case there was more talking and more to say there. Great. Well, thank you so much, Pat, for coming back and joining us. Thank you so much to PCAG members for all of your great comments, especially in our evening meetings. I know they are long days, but hopefully this new time or starting a little later helps people have a minute to breathe, or maybe just to keep working up until a later time. So apologies if that was your experience, but we appreciate it. And I'll send out, we mentioned a couple things at the beginning, and like the link to the recording once the testimony happens on Friday. So I'll probably send out an email early next week or Friday afternoon so that I can wait to package everything. And our next meeting is in March on the third Wednesday, which feels far away, but will come up quickly, I'm sure, especially for Pat with all of this work. So thank you, everyone. And I hope you have a great rest of your evening.
Thank you all so much. Reach out anytime, please. Take care.
Thank you.